Good evening, everyone. Hello, and welcome to this Goodfellow webinar on depression, anxiety, and stress, new ways of assessment and management. This webinar is kindly supported by the Health Promotion Agency. My name is Dr. Grace Lee. I'm a general practitioner for the Goodfellow unit, and I'll be moderating this session tonight. Tonight, I have the pleasure of introducing Professor Bruce Arroll. He is the Director of the Goodfellow unit, Professor of General Practice and Primary Healthcare, and General Practitioner at Greenstone Family Clinic. We also have tonight on our commentating side, Marcia Sassano, and I'm going to let her introduce herself tonight. So she'll be joining us for the Q&A component. Marcia, if you could just let us know your background and just a few comments about how you'll be supporting the session.
Thank you, Grace. It's Marcia Sassano, so I'm a health psychologist. At the moment, I'm the training lead for the Integrated Primary Care in Addictions program with TICPO. And tonight I'm going to be supporting Bruce with some additional comments and answering some questions from I guess a behavioral health consultant experience and background. So hopefully be exciting.
Thank you, Marcia. So without further ado, Bruce, I'll just hand over the presentation to you and we'll get started.
Okay, well, Kia Tato, thanks, Grace, for the introduction. I was just going to add that Marcia is a trainer of HIPs, the Health Improvement Practitioners, which you will be seeing in, many of you will now have a HIP in your practice, and many of you will be getting them in the future. So that's why I've asked Marcia to come along tonight. I'd also like to just thank the Health Promotion Agency, to Haringa Hauora, for supporting tonight and coming up with some of the ideas for us. It's been very, very exciting to work with them. So thank you very much. So we're deliberately calling this depression, anxiety, and stress rather than one or the other, because those of you who have heard me talk before, is I think these labeling somebody with depression or anxiety is very difficult in primary care. And I don't think that's where we should be spending our energy. We should be deciding somebody's distressed, get a measure of it, and then get on and get intervention going. Because we know about half the patients only don't come back for a second visit. So we have one crack at the problem. So that's why, and I don't think our skill set is in labeling people, and labels aren't particularly helpful in primary care. You could almost, Ray Moynihan from Australia says a diagnosis should be more helpful than harm. And I think labels like depression and anxiety can be more harmful to patients. And you will have heard me talk about my patient who missed out on a job with the police because of the label of depression. So we're moving away from that tonight and just using the term stress or distress. So stress or distress can mean different things to different people. And Kelly McGilligan, who's a health psychologist at Stanford, talks about stress when something that is important to us is at risk or at stake, is one way to think of it. And of course, when you think about the things that are important to us, this coincides with our values. So we may be worrying about an illness in a family member if family members are important to us. I also like to think of stress as being life's dashboard warning light. This is a bit like a petrol gauge in your car. When it's showing empty, at some point you have to take action, otherwise you're going to come to a standstill. Some people like to see the lights come on, but I like to get petrol the moment my sign gets, and the same in life too. So figuring out very early on when you're getting distressed is important. So there's 3 steps with stress, again based on Kelly McGonigal, and this can be labeled NRT, which is a nice primary care familiar acronym. Notice your life's dashboard warning light, recognize that something's important to you, are at risk, and then take action now. The take action now is quite important, because if we stew on these things, we can get ourselves into a mess and go down the rabbit hole. So noticing these things, these are some of the various ways of noticing stress. They can be symptoms in our bodies. They can be avoidance and escape activities, so avoiding people, places, and activities, and escaping into drugs and alcohol, or hiding in bed. and too much worried thinking. So there's three sort of things that can happen when we get stressed. So symptoms in our body, these will be common in primary care. We see them every week: racing heart, chest pain, pain in the neck, back, stomach, vague symptoms throughout the body, breathing quickly, not something we necessarily pick up on. Patients will report panic attacks, which of course, if we were there when they had them, we would see them breathing quickly. And I think it's important that we train our patients to know what these symptoms are. It's the first step in taking action. Then there's the avoidance and escape behaviours. And we do the avoidance because we're designed to avoid physical pain to keep us alive. But the mistake we all make as human beings is we try and do the same thing with emotional or personal pain. And that's not the same as physical pain. That's a key point of what we're talking about tonight. This is what we all do it. I always joke, I wake up at 3 o'clock in the morning, even though I teach you this stuff. But I now know to say to myself, I'm trying to problem solve a personal problem. Avoidance and escape. So my own situation is, I know I'm getting stressed is when I don't want to go to the gym. I try and get to the gym 3 or 4 times a week. And when I don't want to go, it's the first sign on my dashboard warning light. It took me 35 years to realize that, but now if I don't want to go to the gym, I just go to the gym. So we avoid people or places. We cut down on activities that give us pleasure. We reduce exercise. We start eating too much food or unhealthy food, and we may increase our alcohol or drug use, or spending time in bed when not asleep. Spending time in bed when not asleep is an important question to ask your patients about. I'm always amazed when somebody says, I spent all weekend in bed, and I'll say to them, did that help? And they'll always say no. Or I drank alcohol all weekend, did that help? No. So although patients don't get any benefit of them, they can keep doing them. They shrink down their world such that there's not a lot of positive reinforcement coming in. You can see where that's going to lead people. And too much worried thinking, we can start feeling panicky or overwhelmed. So recognizing when something is important to us is important. And then again, we only worry about things we care about. So in a funny sort of way, our stress is telling us what's right with us, not what's wrong with us. And this is quite a nice reframe. So rather than thinking it's bad to be worried about the family, well, actually, that's probably a good thing. It shows we care. And so we can flip this. We can flip what is wrong to also make it what's right. We're linking to our values. And I'm going to be talking later in this evening about an approach called assessment of resistance, which is a massive flipping of what's wrong to becoming what's right. And I think it's a major step in terms of psychological treatment for patients. I'm frustrated, flips to I've not given up or I care about things. So quite an interesting way of reframing our distress there. So take action. So this is what Kelly McGonigal will say. Use the energy from our stress for taking action, because stress does activate us initially anyway. We need to learn to approach things, not avoid them. Although if you've got an angry boss, that may not be the person you want to approach. If it's a task that needs doing, clean the house, weed the garden, pay your taxes. If you're a student, do the assignment. And then we need to learn to hold these uncomfortable feelings lightly. And I get my patients to cup their hands like this and hold the uncomfortable feeling lightly. And I'll say to them, I want you to experience this feeling, not try and solve it, because a personal problem really isn't solvable. Somebody insults you at work or at home, you can't, it's not a problem to be solved. It's an experience to be had, no matter how painful or hurtful it is. And remember, our minds don't have a delete button. Our mind's role is to keep us safe, and our mind will not forget any dangerous thing like a boss criticizing us or we make a mistake at work. It won't let us forget that because it's just trying to keep us alive. It's not there to make us happy. It's just there to keep us alive. If you want to be happy, you have to do other things, like approach things, like hold things lightly. And this is the person I heard this from. This is Steve Hayes, He's a professor of psychology in Reno, Nevada, and he was really the brains behind acceptance and commitment therapy. He's sort of in his 70s now, and I saw him speaking at Victoria University in 2015. And he gets up and says, "There's no delete button in the human brain." I go, whoa. And I guess we all know that. We've just never heard anybody say it. So I thought he was a bit of a genius for being able to say it. And then he put his hands down by his belt and just said, well, what do we do with our negative cognitions? We need to hold them lightly. And that sort of put me on this path to understanding this way of dealing with personal or emotional issues. So take action, so otherwise the solution becomes the problem. For example, if we make a mistake at work and we're still awake at 3 a.m., we have two problems. We're worried about the mistake at work and we're tired and sleep deprived. So when I wake up in the middle of the night and I'm starting to think about something that happened during the day, I say to myself, Bruce, you're problem solving a personal issue. And then I put the iPhone buds into my ear and I listen to a podcast and I'm asleep within 10 minutes. So I no longer wake up in the middle of the night to sleep. So but again, it took me 35 years to figure that out. But so I don't stay awake in the middle of the night. Of course, we all wake up in the middle of the night, but we can avoid staying awake in the middle of the night. So as humans, it's not possible to live without stress or suffering. And some say pain, emotional and physical, is to be expected in life. So we need to learn to deal with how to deal with the suffering is important. And we can learn ways of dealing with suffering by reframing it as okay in order to live with ease. I met this Chinese psychologist from Malaysia who was a very strong Buddhist, and she said, suffering's common and suffering's okay. And I thought actually that was quite a good state to get to, that pain and suffering is actually okay, unless we're about to be killed. Usually it's just an uncomfortable experience for us. We don't like it. I'm not saying you have to like it. I'm just saying we need to find. So living with ease. So this is the thing out of acceptance and commitment therapy. Trust your experience is not what your mind's saying. So for example, you're sitting at home, you're a bit bored and your mind says, sit down, have a snack, have a beer, watch some TV. But you can also call upon your experience. When the last time you were feeling a bit bored, you did some exercise and you felt better afterwards. And I would tend to agree with the line that our experience is often a better guide than what your mind is saying. Because remember, it's only trying to keep you alive, not make you happy.
Bruce, can I make just a little comment in that about,
yeah, go for it.
How I guess is how all, we're really attached to feelings that pop in, let's say bored, and which is the one that you brought up, but is the kind of thoughts that those feelings, those emotions elicit, and the associations that we have with previous experiences. So at times, we rely on past experiences or memories of experiences to make the judgment on and a decision about the behavior we're going to engage to. So it's an attention to for the stories that pop out into your mind about, what does it say about me that I'm bored, and how do I solve this feeling of, not being content with how I'm feeling right now. And so those things are quite influential in the decisions that we make as human beings and what we're going to engage into.
It's pulling our past learning into play, isn't it? Which is the problem with language, isn't it? Because we're able to use language to pull in all this negative and good stuff from the past, but it will all, given half a chance, our mind will bring in something negative as it will bring in positive stuff, depending on what's happening with us. And there's some other things here. This comes from Paul Gilbert, the compassion-focused therapy person who we're hoping to do a webinar with in the new year. He was supposed to come this year to the Goodfellow Symposium, but COVID put paid to that. And this is a very nice question. I find it a really good question to ask teenagers. What's the emotional tone of the conversation going on in your mind? Is it critical or kind? And I find teenagers pretty hard to deal with because they're usually sitting in my office scowling at mum and scowling at me and wondering why they're there. And I asked them this, And I think they think I can read their minds because they make instant eye contact with me and they'll tell me really negative stuff. The first kid I said this to, he said, well, he's 17 and he's anxious. He says, I call myself a piece of shit. And I said, well, it's no wonder you're anxious. It's like, you know, somebody yelling back at you isn't going to make you feel good. And I find, so if you do deal with teenagers, that is a really good conversation opener. I didn't realize that, but it does gets them connected and talking about it. And so then I say, well, are you willing to develop a kind voice in your mind? Perhaps a supportive coach instead of a critical coach. I used to say, do you want a sergeant major or a supportive coach? But I discovered most young people don't know what a sergeant major is. So I've had to adapt. Do you know what a sergeant major is? No. Okay. So obviously an old-fashioned military term. So then the other way to think about is our minds as being a tiger alarm. And we can think about our mind as a tiger alarm, which keeps us alive. And the tiger alarm is a bit like a smoke detector. It knows something's wrong, but it can't tell the difference between the toast burning, which is a relatively benign activity, or the house burning down. From the brain's point of view, once you set the tiger alarm going, the tiger's in front of you. That's the problem. And so we need to learn ways of turning our tiger alarm off or down. The quickest way to turn the tiger alarm off or down is to breathe slowly. And Marcia, you'll be pleased to know I was up in Kaitaia a few weeks ago, and Tanya showed me how to do the 4-2-4. She gets the patient's hand up like this, and you breathe in for 4, and you just run your finger over your hand, hold it for 2, and down for 4. So I don't know if you taught her that, but it's very nice because it brings the touch and it helps slow the breathing. So it's 4 seconds in, hold it for 2, 4 seconds out. 4 seconds in, 2 seconds hold, 4 seconds out. And that just slows the breathing down, which of course damps down the sympathetic nervous system, slows the heart rate, takes the tension, and you see people going out of their heads into their bodies. It's quite dramatic. You really feel this change from that point. Another way of slowing the heart rate is keeping fit and active, and then using the steps: notice, recognize, and take action to manage your stress. So in terms of summary, the 3 steps for stress is the NRT: notice your dashboard warning light, recognize when something important is at stake, and take action now or hold it lightly. Learn to turn off the tiger alarm, so 4-2-4 breathing method. Learn to trust your experience, not what your mind's saying. Practice being kind to yourself. Develop your internal supportive coach, and regular exercise, keeping fit and active to slow your heart, and practice living with ease. Can't live without some pain and suffering, but we can live with ease.
And Bruce, if I can just say
about
being kind to yourself, it's probably one of the trickiest things to convince someone to do. Being kind to yourself somehow is associated with a belief of worthiness or a belief of deserving. And so teaching kindness, it actually takes a long time, and it's okay to get it wrong. I think, oftentimes when I talk to patients about kindness and being kind to oneself, I often kind of transmit that into another person. So if I in a way reframing, if I were your friend coming to you with this story, what kind words would you have for me, and how would you show kindness to me? And so in that way, can kind of put it into behavior what kindness actually looks like.
Yeah,
but
no,
it is
that's
a tough
nice.
one.
I've found one of Paul Gilbert's saying, cultivate the voice of self-kindness, quite good. And I'll often describe when I'm going on the motorway and somebody cuts me off and I'm contemplating a bit of road rage, and I just say, cultivate the voice of self-kindness, and I can just feel my adrenal glands turn off. Bam, I just feel a calm person. So again, that's taken 35 years to figure out. So I'm a very slow learner. So. Okay, so we've got a couple of cases to go through here.
Bruce, just before we go into that, I was just wondering if I could ask a question or two. That's okay.
Sorry? Yeah,
I was
yeah,
just
go
wondering
for
if
it.
I could ask a question or two before we move on to the case.
Yeah, yeah, please do.
If you wouldn't mind just sort of popping back to that summary slide set, just the page before, that's great. Now, you've given some really good examples with regards to statements of how you would talk about turning off your tiger alarm, or alluding to the concept of taking action and holding uncomfortable concepts lightly. Those are really useful terms to use, but I was wondering, both Marcia and Bruce, in your clinical day-to-day practice, you must obviously see a wide variety of individuals that come in. So how would you adapt your language to different cohorts, for example, people that have different cultural experiences, ethnicities, and age groups?
Marcia, do you want to deal with that?
Great question. English is my second language, so I find it really hard to understand what hold something lightly mean if it is not, a cup or an insect or a baby. This notion, this abstract notion that I can hold my feelings lightly, was something that took me a long time to wrap my mind around it. But I guess is the way that I have to understand it is not try to do something with it. Is if I can just notice that it's there, and kind of watch it like from a curious kind of, almost like if I never seen that thing before, or never experienced that thing before, if I could just watch it and see the transition that it has, like a lava lamp in a way, if I could just watch it and not try to stop it and not try to engage with it, not try to disprove it or argue with it or be angry with it, if I can just notice that it's there. And it's a great strategy that I guess to teach you this observing exercise in the way of even positive emotions. If I get you to, for example, right now, to notice what are you feeling there, if there is a particular emotion that you're feeling there, like maybe boredom or excitement, or what does that feel like in you? Where do you notice it? Where in your body is it? And how do you know it's there? And how do you know how long it's been there? Or can you watch it move from there? So that's one of the concepts for me that it was hardest to understand and hardest to explain, because I don't know if it's English second language thing, but that's how I do explain to my patients.
Interesting, Marcia used the word curiosity there, and that's quite an important word, I think, because it gives patients, it puts some distance between them and the emotion. The problem with stress is that we hold it very tight to ourselves, and just being curious about it makes us take a step back, which is actually quite an important. There's quite a nice little technique you can use. I'm feeling worried about my upcoming exam. And so I get patients to say this to me. If they say, well, I'm worried about an upcoming exam, I'll say, I'm having a thought that I'm worried about my upcoming exam. I'm noticing that I'm having a thought that I'm worried about an upcoming exam. I'm noticing that I'm noticing. And they can feel it moving away from them. In fact, acceptance and commitment therapy was originally called comprehensive distancing. And I wonder if that was part of it. And it's quite a nice strategy to get patients, I think, to let go that. But I guess the other thing, Marcia alludes to the language thing. It's pretty hard to do that if people don't have a reasonable grasp of English. Well, I always say it's very hard to do this stuff if you can't speak the same first language as your patients. And I only speak one language with any skills. So it is a bit of an issue. And I think we simplify, we make a bit of a guess at people's health literacy. And like, I don't use the word self-compassion, I'll use the word self-kindness. If I think self-compassion is sort of a fairly academic word. So I think GPs are pretty good at that, actually, GPs and nurses in primary care, because they're doing it all the time. We're translating the hospital stuff in for our patients, and they're a bit confused about what's happened at hospital. So I think we're natural translators, interpreters in that sense. So,
I think that's a great point. I think it also for my practice as a health improvement practitioner, I do a lot of modeling. So I will refer often back to patients and say, oh, I'm noticing how you're talking about yourself in there. Is that something that happens very often? Or I just notice how you're just put yourself down just that in that comment. Is that something that happens very often? And so modeling that you're noticing certain aspects of the way they do talk about themselves. It's a reflection, I guess, on the cognitive processing that is happening for them.
And it is quite interesting, that thing you were alluding to, that we can talk to ourselves in a far worse tone than we would ever speak to another human being or an animal. It really is. The internal dialogue can be vicious in somebody who would never use that sort of externally, which is which is again the product of language, our great tool as high primates, but also our great enemy in many ways. Okay, shall we get on with the first case?
Sounds good, thank you.
Okay, so this is Michelle. She came to see me. She's aged about 50, and her PHQ-9 was 20, which would put her into the severe range. Her emotional quality of life was 20. So this is a quick term I've invented and validated. So I ask patients, if I'd like to know what your emotional quality of life is now. If 100's perfect and 0's worst imaginable, where are you now? And this turns out to be very specific. It's not very sensitive, but any score below 50 is associated with a PHQ-9 over 10. So anything below 50, the patient has a bit of a mood problem. So that's the EMA-QOL there. It takes 15 seconds to do, so long as people can understand what you're saying. They don't need their glasses. If they can't read, and remember, a number of our patients are illiterate, but they won't tell you. They'll just say they haven't got their glasses. So you have to watch out for that. And scores below 50, the PHQ-9 is greater than 10, almost always. Very high specificity. Not so good when it's over 50, but there's not such a problem when the score's over 50. You've got a big problem with motivation below 50. So this woman was angry at her ex-husband because he'd make an arrangement to meet their 23-year-old daughter, so they'd have a date and he wouldn't turn up. And so she was getting angry on behalf of the daughter. So I assessed that this lady was pretty distressed. I got her to do the work-love-play questionnaire, which I think there's a copy on the website. If not, we'll put it up there. It's on my website, brucearroll.com, if you want a copy. We have it installed in our MedTech now, which means it puts the patient's name and date of birth and NHI on it. I fill it out and I scan it into the notes, so it's there. And as a passing comment, I said, well, maybe while we're doing this work, you can look at forgiving your ex-husband because you're the one who's suffering. And I always point out that forgiveness isn't about letting the other person off the hook, it's letting yourself off the hook. I think it's very powerful if people can do an act of forgiveness. But anyway, so I just left that. And this was her work-love-play. So 5 out of 10 for work. Lovers and friends. She'd stopped seeing her friends. Very typical of people who are distressed. She didn't have an intimate partner, a current partner. Family was okay, 7, and she'd stopped playing. So this is interesting. This is a fairly typical pattern. The most predictable things for a low mood are for lovers and friends to drop down and play. And when the statistician was looking at these things, he said, well, you can't change your work very quickly. You can't change your intimate partners very quickly. You can't change your family very quickly, but you can change it. You can do something with your friends and you can do something with play and recreation. And so lovers and friends and play and recreation are where I usually target things. I might ask questions about what's going on at work, but it's a 5 out of 10. But in terms of the first steps are usually to get people contacting their friends, doing pleasurable things, and exercising. Always get people exercising. I rarely see anybody who's distressed and physically fit. I have a colleague who's a nurse practitioner in Wanaka, and she says, well, there, everyone's fit, you know, every distressed. So it depends where you are. But in Auckland, most distressed patients, unless they're professional athletes or personal coaches, they'll invariably have stopped exercising. And come further down, so those are the top 5 things on work, love, play. And then I asked specific questions. Exercise she wasn't doing, doesn't do alcohol, drugs, or smoking. Sleep was okay, doesn't belong to any clubs, doesn't have a spiritual aspect. Her values were her children and her family and animals. And when I asked her about trauma, she said she had an argument with her mother over her ex-husband. So, and it was interesting asking her what her friends thought of her ex-husband, and they didn't like her. It's just something I'm working on at the moment as a test for good relationships. What do your friends think of your relationship? Anyway, that's a work and play. So these were the avoidance and escapes. So she stopped exercising, stopped seeing her friends, stopped doing pleasurable activities. So what's her diagnosis? I'm playing with a term like distress with reduced motivation. I mean, you could say she had a severe depression or severe depressive symptoms, but I don't think that would help very much. By saying she's distressed with reduced motivation, I will then target her reduced motivation. Should we use drugs or talk? Well, you will have seen my data about behavioural activation. Hopefully, those of you who came to Red Whale, the top treatments for depression are behavioural activation, NNT of 2.5, CBT 2.8 to 7.3, and drugs will work for the very severe patient, NNT of 4. But when you drop down to severe, the NNT goes up to 11, and mild to moderate goes up to 16. And in a primary care study we did, at 1 week, 50% of people were better at 1 week with behavioural activation compared to 21% with control activity.
Must I say there, Bruce? So sorry, must I say there with the CBT, I guess behavior activation is the aspect of CBT that has most consistent positive evidence for in all the CBT components. The behavior activation is always the thing that is actually making a difference for patients.
And I think the reason why it may be as good as, if not better, I mean, the problem with this information, of course, it depends what you use as your control group. A lot of psychology trials use waiting lists, which, of course, if you're in the waiting list, you're pretty cheesed off. And that isn't a good thing to be when you're depressed. But I think the thing with behavioural activation is it's so easy to teach people how to do, and it's very portable. CBT takes many years to learn how to do. There are many studies where they've trained people to do behavioural activation in just minimal time. And it's very easy to do in primary care, basically, very easy. So this is basically, now for those of you who at Red Whale, this will be repeat, but I'm just going to show you, this is the data from the FDA. This is severity along the baseline. This is improvement in mood, reduction in mood score. That's drug, and that's placebo. As I say to people, this could be anything in healthcare. This could be cholesterol or hypertension. So we always have a placebo effect, and then the drug effect is a little bit better. The drugs get more effective the more severe the depression. But this is the effect size. The effect size down here is about 25%. However, the placebo rate is 41%. So the placebo rate's always bigger than the drug effect. So they're not hugely effective, although an NNT of 4 is pretty good. But of course, getting fairly feeble when we go, this is severe depression, this is mild to moderate. But this is the key thing in primary care. This is visit 1. And I'm just, maybe I can say this if you're referring a patient to a hip, don't start them on an antidepressant, because after they've seen you, they will be a little bit better. And they'll come and see the hip, or they'll come and see me when my colleagues refer me patients. And if they get given an antidepressant at this visit, they think the antidepressants made them better. Whereas actually they've talked to the GP or nurse, been given some hope, and given some tasks to do, and they will be feeling better. And we know that 85% of people follow this trajectory over time. About 15% stay down here, and they will need medication and they will need psychotherapy. But keep the antidepressant gun in the holster for the first visit.
Oh, I'm so pleased you said that, Bruce. I'm so pleased because, you know, as a health improvement practitioner, what we've noticed in the practice where there are HIPs, the prescribing of psychotropics has gone down quite considerably. And so I'm very pleased with that instruction there.
Yeah.
Really
well, of course, the problem with giving somebody a psychotropic, if they think it's helped them, and they get a placebo effect, which is the most likely effect, then life turns to custard and they feel bad again. And primary care is full of patients who are depressed or got high PHQ-9s, I won't say they're depressed, and they're still on SSRIs, and they don't want to stop them because they're worried they're going to feel worse. Indeed. So we have an enormous number of people in primary care. I must do a survey in our practice and just see how many people are on long-term SSRIs and they're not any better. And they need to have something different. But of course, you can understand, nobody wants to feel, if they're feeling very depressed, extremely depressed. I mean, it is a terrible thing. Okay, so so we did behavioral activation with this lady. I suggested she do 2 tasks. She agreed. She would catch up with her friend Janet, whom she hadn't heard for a while, and they would go dancing. And I negotiated whether she would, how likely she was to do this. I used likely rather than confidence because I sort of want to know. I want the cards on the table. Not so much interested in confidence. She said she'd do it 7 out of 10. That's good. Twice a week she'd go for a walk and listen to Shortland Street on her earphones while she was walking, and that was 8 out of 10. That was quite interesting. When she finally caught up with Janet, Janet was annoyed that Michelle had got distressed and hadn't kept up with her because they're good friends, okay? And on average, women have 2 good friends, close friends. Men have none, interestingly, and that's based on data. So the test of a close, intimate friend is that if the friend leaves town, you'll keep in touch with them, and women do that. Men generally find somebody else to do things with. But I'm told by some of my younger colleagues that younger men are different these days. Absolutely true for my generation. So my friends leave town, they don't keep in touch with me. So in spite of me trying to keep in touch with them. So a week later, her quality of life score was 25. I didn't do any other things because this saves time. And she said to me, look, I don't think I can do the forgiveness thing you mentioned last time. And remember, I just sort of said this in passing. So I thought, oh, okay. And so I said, well, let's put hubby over in the empty chair across from the room. And I said, well, what do you think about him sitting there, you know, in absentia? And she says, I want to strangle him. So there I am. So I just would like to ask the audience if you could think about what you might do at this point, and then I'll tell you what I did, which turned out to be quite a breakthrough for her. But you know, you've got a potential homicidal situation on your hands. What are you going to do? Do we have any questions, Grace?
We do. I was going to batch them. Can you take a few now? Would that be a possibility while we're waiting for a little bit of feedback?
And if anyone's got how they would handle this, then I would be interested to hear. So yeah, go for the questions.
Okay. All right. So to quick fire, firstly, how are you going to fit this in a 15-minute appointment if you've got a whole lot of other things that a patient comes to you to deal with in that particular appointment?
Well, I mean, you can refer them to the HIPs if you want, if you detect the distress. That's, if you haven't got a HIP, you need to get them behaviourally activated. So, the problem in primary care, of course, you spend 14 minutes doing all the other stuff, and then they say, my wife's left me, I've lost my job. So I do a quick quality of life score and get them to behaviourally activate. Like I just say, make sure you do some exercise and contact some friends, and I'll see you next week, or I'll see you as soon as possible. It's important to try and see people as quickly as possible. That can be difficult in a primary care timeframe. But you know, unless we learn to get people back, we're never going to be of maximum care health to our patients.
Okay,
Do you have any tips for that?
Look, for the behavior activation, I think, I mean, if the practice has a hip, then things are much easier, because then as the point where distress is disclosed, you can send it to the hip. But, you know, hips can also do this kind of work in 15 minutes. And it typically is just understanding quickly with the context of the difficulties. So we do typically a function, the analysis, I guess the conceptualization is based on the impact that distress is causing in functioning. And functioning is what they've been doing. And the moment you highlight, oh, this is, you've been drinking more, you know, if that is that possibly a way of changing things. So it's kind of tapping into how the behavior has changed in context of that problem.
Okay, all right.
Yeah, and one of the things I say, the other thing, it's always, you've got to ask about alcohol, because I remember we had a counsellor in our clinic, and whenever she saw patients, they were drinking enormous amounts of alcohol. I go back and look at their notes, and the last time I asked them, they were a social drinker. But of course, they were a social drinker when life was going well. When life turns to custard, up goes the alcohol because of the instant benefit. But of course, I always say to patients, you fly now and pay later. Of course, it's self-medicating. I always say to people, look, I have no moral issue with alcohol, but if you're drinking a bottle of wine a day, that's not good for your physical health or your mental health. So, other questions, Grace?
Yes, we need a definition of a HIP for those individuals out there in the audience that aren't quite sure of the role of a HIP. So Marcia, would you be able to tell us a little bit more about that?
You're on stage, Marcia.
Oh, that's me. Thank you for that question. I really appreciate it. So a HIP is a health improvement practitioner. This is from a primary care behavior health model from the United States that has been introduced to New Zealand now under a different name. So a health improvement practitioner model. In a HIP is just a behavioral health consultant, just how the New Zealand decided to call that. So behavioral health consultants help in the GP practice with all the behavioral health difficulties that patient might present, including mental health stuff.
Okay.
And so when you say behavioral health, they're often usually psychologists of one sort or another, counsellors, mental health nurses. There's an occasional GP. There's a couple of GPs doing it.
That's right. We have a psychiatrist doing it.
Sorry?
We have a psychiatrist doing it in Wanganui at the moment.
Yeah. So there's a range of people. And you do what's called a warm handover. In North America, it's called a handoff. But when I went to North America, I couldn't say hand off. I said handover. And I noticed it's used handover here. I think handoff is a bit too rough for Kiwis. Handover is a kind of gentler word. Is that true?
That's right. So the behavioral health consultant is is fully integrated into the practice, so it has access to the patient management system and GPs and nurses. And GPs and nurses are the primary referrers. So we are working in a consultant capacity. So primary consumer for HIPs are actually the GPs and nurses. So our templates reflect I guess the productivity level that we want, which is 10, 12, 14 patients a day, depending how long you're in the practice. So you're able to help a lot more people. And the warm handover is just a symbol, I guess, of the preference for same day appointments. So we want to consult with your patient on a day they present with distress, rather than book a referral and get them to come back another day. So it's another commitment, another time. And we know patients don't come back.
How do we get access to a HIP?
The way you do that, Marcia, is you keep every second appointment free when you arrive for a day, don't you? So you've got spaces.
Yeah.
And we know that 95% of patients get seen. When you refer them out to another agency, only half of them turn up. And I guess we all know that with our so-called emotional mental health patients, half of them don't turn up. So it's
actually more, it's more than like the 30% of patients don't engage to external service, even including specialty service. So to get a HIP, I guess there is a national rollout at the moment. HIPs are funded, so absolute free service to your practice. with TPO responsible for the training of the health improvement practitioners across the country, but we have HIPs now about 120 or something HIPs, including all over the place in Kaikohi and Taumarunui, just being Balclutha down south. So there is a kind of a national rollout, and regions are going to be going in depending on the needs and depending on the size of the practices.
Okay, well,
Okay.
I'll just feedback to some of the comments.
Got anyone come up with some suggestions for this lady?
Yes, quite interesting commentary. I'll try and round up some of the key comments. So we've had someone, we've had some suggestions with regards to encouraging the patient to utilize their imagination in terms of doing the physical act of strangling, and then ask how she feels afterwards. That was probably actually the predominant one there out of several comments that came through. In fact, actually, that is the core comment out of the majority of comments that were there. Now, what was your solution and your answer to this particular case?
So anyway, well, it's quite interesting because you just assume he's got poor parenting skills. So I thought, well, I'll find out what sort of parenting he had. And the first thing Michelle said to me was that, well, his father left the family when he was 7 years old. And one of the things I quite like, and I'll talk about in a moment, is transactional analysis. Those of you who have been around a very long time will remember the book I'm Okay, You're Okay, written by Eric Byrne. This is going back to the 1970s, where you relate to people either as a parent, adult, or child. And so you could look at this guy as the wounded child. He hasn't had a good experience of fathering, so he doesn't know how to be a good father. So he makes a date with his 23-year-old daughter and doesn't turn up. That's really bad parenting, So in transactional analysis, he's behaving like a child, and Michelle's in a sense acting like a parent because she's angry at him and wants to tell him off. So this was a massive. She didn't want to strangle him. I said, there's a 7-year-old boy over there. Do you still want to strangle him? She said, no, couldn't possibly do that. And that was a massive pivot point for her. And she really sort of got it. So this is transactional analysis. So ideally we have adult to adult relationships, but we can have parent to child, child to parent. I saw quite a bit of this over COVID actually with 20 to 30-year-olds moving home. And of course they move back home with mum and dad, and mum and dad start treating them like they're teenagers. And it was not an uncommon situation. One woman had lost her job, and her mum said, well, now you haven't got a job, you can start doing things for me. And she was wanting to look for a job. So as I say, quite an interesting way of thinking about human relationships. And this is where we want to, so if any of you are interested, I'm okay, you're okay. He's almost 50 years now. Eric Byrne died. He was a psychiatrist in the UK, died a long time ago, but people still train in this. And I think sometimes it does have utility to think of like what's going on here. And often I warn people when they go home, they have to watch out that they have an adult-to-adult relationship with their parent, because we all slip into our roles and we become a parent again. The 20-year-old comes home and we start to behave like a parent. So, and this comes out of Steve Hayes' book, A Liberated Mind. Now I've simplified this down, but this is what we call a here now versus a there then frame. This is one of the key distinctions that come out of the theory of language behind ACT. And you won't have seen this, Marcia, the cut down version, but I think it's much cleaner than Steve's original one. So it's there then when he's 7, and this is him here and now, not performing very well. Although for Michelle, of course, once she understood that distinction, she could be more flexible and fluid and voluntary attention. So anyway, 10 days later, her quality of life score was up to 47. And the funny thing was, she started to feeling kindly towards her ex-husband. And I had to caution her, you don't want to remarry the 7-year-old. You've divorced him once, And the daughter found this very helpful too. So it sort of explained his behavior. So their expectations of him went down and their understanding of him went up. So I don't know whether it won't necessarily improve his behavior, but I mean, this family had a big schism in it, and at least they had a more flexible approach to him. And this is her, for some reason I saw her 4 days later. Her PHQ-9 was 7 at that point, quality of life was 56. And then 4 weeks later, quality of life was up to 80, PHQ-9 was down to 3. She was back in full remission and back in the river of life. So that required a reframe for her. But reframing, of course, is something we can do in practice, and it requires, you know, a little bit of experience and to try and get the patient to see the world through somebody else's idea. Because the problem with couples, of course, they're usually blaming each other, and you've got to get them to sort of get some perspective on that and stop the blame game. Okay, so we've done 2 new assessments there. We've done the EMAQUAL 100, takes only 15 seconds. So if you don't need a named questionnaire, this is a pretty good way. We have to use a PHQ-9 in counties to get paid extra for the consultations we do. We have a thing called a wellness fund, so we can spend extra time with patients. And then with work, love, play, so the top 5 questions have a 1 to 10 scale. So if you add up the score there, it's below 35. The PHQ-9 is usually over 10. But you see the scores down on this side of the sheet of paper, and you know you're dealing with a flat person. A fully functioning person will be 7, 8, 9 out of 10. They'll be straight lining there. And it gives you a very quick summary of the avoidance and escape behavior, which needs reversing. Okay, so the key thing in behavioral activation is to reverse the avoidance and escape behavior. So, Marcia, any comments on that at all?
Oh, beautifully done and work on reframing, Bruce. And the only thing that I can say there is the reframing doesn't take very long at all. I don't think, you know, sometimes it can be just a shift from inviting the patient to sit on your chair and you sit on their chair, and what is that perspective? And just that perspective change can be a massive opportunity for patients to start seeing themselves through a different way. So I was just going to highlight there that this perspective changing doesn't take a lot of time at all, I think also if we look at how we bring as humans, we bring our own context and understanding of what's happening around us. So we use that bias of us here now and everything that happened to me in the past to make inferences about what's going on around me. And so that context is actually very, very normal. So a little change could mean a massive assumption change in what resources the other person has, because I'm looking from the outside. I should expect you, grown person, to have the resources of a grown adult, well-functioning person. So it's beautifully done, Bruce.
Yeah, and I'm sure many in the audience, I mean, I often think I have these, I used to call them sort of like a moment of brilliance. I mean, it sounds a bit self-grandiose. And often I get to the end of the consult and I can't remember what I did. I just remember there was something clever. And usually it's a reframe that the patient gets. Of course, patients don't always get the reframe, and then you're a bit stuck. But if they do get the reframe, they can see the world, they can see themselves as others see them, can be very useful. And it may just be a self-esteem thing sometimes. You know, people, you can, and we're going to talk about a massive reframing before the end tonight. So this is case number 2. This is Leslie, age 55. So her PHQ-9 at baseline was 16 out of 27, moderate to severe mood problems. GAD was 10 out of 21. That's more the so-called anxiety, moderate to severe. And this is a very common pattern. And if you look at the health pathways, you could give this lady an antidepressant at the first visit. You could have given the first lady an antidepressant, but I think we'd all agree that actually we got her better without it, or she got better without it. What made the difference, I guess, is up. And her quality of life score was 35 out of 100, which you can guess. I can guess a PHQ-9 from the quality of life score. 35 equates with, you know, the lower the EMA-QOL, the higher the PHQ-9. So once, if you use these things a lot, you can pretty well guess. But if you don't measure somebody's state, you may get it wrong. I think there is a, and it doesn't matter what you use. If you're using the Kessler, that's fine. If you use a Beck, and counties, they're starting to use the Duke, which is what the HIPs use. I don't think it matters. It's all just some measure of how severe they are. Because if they don't get better over 3 or 4 weeks, then you might want to start talking about medication. That's the time to have the medication discussion. But I don't think we should be giving medication to people unless they've got their life completely under control and they're still flat as a pancake, or they're going to lose their job next week. Sometimes there's contextual issues. They're going to the gym, they're keeping up with their friends, they're still not doing very well. That's somebody I think you might want to give a medication to it at the first visit. But as I say, 7% of my patients get an antidepressant at the first visit, and it's always because they're insisting. They come in saying, I want an antidepressant, so give it to me. And that requires a lot of energy on my part to sort of turn around. Okay, so life wasn't going well. Staff weren't being replaced at work. She started crying, so I used the line, if your tears were words, what would they be saying? And that's from David Cool. You may remember David Cool was a keynote at the symposium 3 or 4 years ago, one of his sayings. And she said, I'm not worth anything. Now that's great, because the advantage with tears is people, in terms of cognitive behavioural therapy, are giving you a core belief. That's their pain. So you can work with that pain to do something about it, train them to hold it lightly. And not finish. I just said, well, that's a very painful feeling, isn't it? If you're telling yourself I'm not worth anything, then your mind's not going to like that. That's going to set off the tiger alarm. So this lady's tiger alarm was well and truly activated. And so we had to give her. This was her work, love, play. So work was 2 out of 10, because she's so lovers and friends was 8. Intimate, she was separated from her alcoholic husband. Family was 10, and play was 3. So again, that's a fairly typical. She actually said she wasn't contacting her friends. So although she, you know, her friends were okay in the history taking. So again, this is what I call a sawtooth pattern. Low on that, high on that, low on that, high on that, low on that. So you see this shark's tooth pattern commonly. So again, we're going to get her moving with her friends and get her in. She'd said she'd walked a half marathon, so I knew exercise was going to be a thing. And again, this is available at brucearroll.com if you want to have a look at it. Everything's free there. So, and you can get the work love play sheet if you want to use it for your clinic. And when my colleagues use the work love play sheet, they will say, boy, it's just so obvious what needs to be done. I mean, it's absolutely crystal clear what's missing in the patient's life. So exercise, no. Smoke and alcohol, no. Sleep wasn't good because she did shift work. She belonged to Al-Anon because her ex-husband had been an alcoholic. Had no spiritual component. Work and family were her values. I always ask about values. In fact, I'm thinking about adding the dashboard warning light to this questionnaire, just so people get the idea of what the dashboard warning light is. And she hadn't had any trauma. The way I ask the trauma question, I say, and remember, actually, all of us have some trauma in our lives. All of us have probably been in some sort of motor vehicle accident. We've fallen off bikes. We've been bullied at school. We might have been in a fight in the playground growing up. Might have been in a fight as an adult. So trauma is sort of universal. So I say to people, have you had any trauma in your life that you feel is unresolved at the moment? And that will sometimes completely change the consultation, of course. You know, sexual abuse may come up, physical abuse as a child or an adult, all sorts of things. But I think if you don't ask that question, you're in danger of missing. If it is an issue and it is unresolved, it's going to get in the way of treatment. I don't know whether you want to make a comment at that point, Marcia or Grace. some comment about that, the trauma question?
It is a good opportunity for the HIP also to ask about trauma. We don't necessarily bring it up that often, I must say. Reason being is because we don't want the behavior health to be taken over by mental health aspects. But inevitably, when you are interested in a person's context, and when we ask about love, work, play, health, we are asking about their background and their context, and often the adverse childhood events will come up then, and oftentimes they're not even the different kind of traumas that people experience. There is even worrying about money, where money for food is going to come from, or witnessing domestic violence in the home, or having the parents separate, or so trauma, it has a variety of presentations, and it is quite important to have that, because we know trauma can have a significant impact on mortality and morbidity.
The reason I added it, I'd been seeing a lady for a number of visits, and I never quite figured her out. And she came back to me a year later and said, well, I realized eventually that I'd been sexually abused as a child, and I went and saw a psychologist and got better. So I didn't fix it. The psychologist sort of fixed it, and I thought, well, boy, I missed a big one there. And so I added it to my work, love, play. Any questions coming up, Grace, that you want to?
There are, Bruce. We're just sort of running it just after 8:30, so we're at 8:32 at the moment. So I thought it might be a good opportunity for you to go through the cases that you'd like to bring to us today. And if we've got a little bit of time at the end, then we can wrap up with some questions.
Okay, we'll keep going. Okay, so she wasn't exercising, not seeing friends, not seeing pleasurable activities. So what's her diagnosis? Again, I would say distress with reduced motivation. That's a transdiagnostic term. We could say reduced mood with reduced motivation. If you need a WINS code, you can use adjustment reaction. It's an official read code that will get somebody a sickness benefit. But if you give them a big label like major depressive disorder, it may cost them a job later on, or it may bump up their life insurance or medical insurance. So just be very careful with labels. Alan, I'm trying to the guy from America, says that most labels in primary care are wrong, and with more time and more times per visit, we would, most of those labels would disappear. Alan Francis, he was supposed to be coming to New Zealand this year, but he may be coming next year. Okay, so she wasn't exercising, not seeing friends, no pleasurable activities. So she agreed to see Susan, 8 out of 10. She said she'd walk every day, 6 out of 10. So I said, well, that may not happen. How could we get it up to 7? She said, well, I walk every other day. That would be an 8 out of 10. So that negotiation step is crucial. If you wonder why patients don't do things you've discussed with them, it's because you don't do this step. It's absolutely essential to do that step. So a week later, PHQ 9 was 16. It dropped down to 4. Hemoqual was 80. Her GAD had gone down to 3. So she was completely better a week later. And there's evidence that with behavioral activation, these remissions are sustained. Okay, so I'm just going to talk a little bit about, I've been listening to a podcast called Feeling Good by Dr. David Burns, who wrote a book 30 years ago called Feeling Good, sold 5 million copies. He gets 100,000 downloads a week with this. And the podcast I'm talking about is on the web, I think. You might want to just check with Paul. I emailed it to him. Listen to minute 28 to 53, where he talks to this woman with lung cancer, and it's terminal. She's non-smoker, so she's one of the people who got lung cancer, although she had been a heavy drinker. He got her to do a thing called the Daily Mood Journal, and she'd circled, I'm depressed, I'm anxious, I'm lonely, and a bunch of other symptoms. So this is what it looks like. This is the daily mood log, and this is out of his book. He's just written a book called Feeling Great, which is out of print already. It's a bestseller in America. Went out of print before it even came out. So she reported each of these was 100%, and these were the negative thoughts she got. So this comes out of cognitive behavioral therapy, but I think he makes CBT fun. So anyway, so what he does is say, well, not what is wrong with you, but what's right. So he goes back and says, What's right about you about being sad, blue, depressed, or down, or unhappy? What does it say about you and your core values? It's positive and awesome. What are the potential benefits of this feeling? And this is what she says: being sad, blue, depressed, down, or unhappy. It shows that I'm sensitive, shows that I have a sense of awe for life, a profound appreciation of life, an awareness of the beauty and preciousness of life, are appropriate given what has happened, make me feel alive. So you're listening to this woman do this as she unbundles her stuff. This is the book, Feeling Great. Probably worth getting if you're interested. They're going to reprint it, of course. It's going to sell 5 million as well, I think. So then he does this little game called I've Got a Magic Button. They used to call this paradoxical agenda setting, and this is a paradox you're putting into the patient's mind. He now calls it assessment of resistance. So he said to Marilyn, I've got a magic button, and I can make all those uncomfortable feelings go away. I say teams because that means thoughts, emotions, associations, memories, and sensations. So I can make all the good ones go away, all the bad ones go away. But the problem is all the good ones will go away as well. Do you want me to do it? And she sort of says no. Okay, so that's the paradox, which I like the word paradox. I really like paradoxes. So then he says, well, okay, well, I have a magic dial. Could we dial down these negative emotions to a lower level such that it's manageable, but you keep the good things? So she keeps he gets the patients fighting to keep some of their negative thoughts and emotions, which gives them a different perspective on them, which I think is really clever. I think this is the most clever thing I've seen in a long time. So this is her. So after he does the magic dial, this is what she scores. And then he does a variety of techniques that he's invented called, so literally by the end of this is 25 minutes later, this is what she's scoring. And he claims to, if he spends 2 to 3 hours with people, of course we don't have this time, he can get most people feeling better. Now he doesn't have data to show that up, but he says people, this is a very consistent finding. So that's a baseline, that's the magic button, magic dial, and then that's after doing some CBT thoughts. So Marcia, any comments on that at all?
It's a fantastic work of reframing, really. If you think of, in reconnecting the person with values, in values work, I mean, that's great that you can do in a lot of time, but it can be a brief moment in a session that can reconnect the person with what is important to them.
And well, I've started doing this bit. I've started just taking one of these things and saying, what does this say about you that's awesome and positive and powerful? Because we don't have the time to do this. We don't have 2 hours. But you can just take one of those things. And I have seen pretty well everybody dial down to about this level, somewhere between about 20 and 45. People will dial down from very high scores. So it's very, very interesting. I think it is a reframe. So Grace, I think maybe we'll take the questions. The next case is called, I'll just show it, just choice point. So this is a choice point from Russ Harris. If you go to my website, down at the advanced videos, there's a short video on the choice point. This comes from Russ Harris in Australia. If you put Russ Harris choice point, you can get this graph, and it's about behavior change. Again, you can get people, this was the man who was quite violent. But I'll leave that and maybe just take the questions from Marcia and me.
Okay, thanks, Bruce. Now, there's a lovely comment that was emailed earlier on during the week, which I'd like to share. I think it's really, really relevant. So someone sent in, a generation ago, GPs were worried about underdiagnosing depression. Has the pendulum slipped and swung too far in the other direction, with patients and doctors ready to medicalise natural lows of life and embrace antidepressants? What are your thoughts on that?
Marcia, do you want to go first?
Yeah, I think, absolute response to the need. I mean, we live now in a very health is more accessible than ever been before, and yet we find ourselves sicker and sicker. And I think antidepressants were there to address a need, and yet we find ourselves even more depressed, more anxious. So it served a point, I guess, in the what was we were able to do. But as technology and behavior science has improved, and we're more accessible now, we feel like perhaps, yes, perhaps we shouldn't be labeling people. And even if you look at the labeling system that we have, which is the DSM, and in labeling mental illness, even an agreement in that is difficult to get, and in a match of perfect symptoms, and it's difficult to find. So I feel like we are finally in a good trajectory to normalize human experiences, human distress, and effectively giving people strategies for managing these difficult times in their lives.
Yes,
Okay.
I think historically we probably missed a lot of distress, and then we went through a stage of feeling like we had to make a diagnosis. But I don't think our core skills are in making a mental health diagnosis. I need a diagnosis about once every 200 patients. One patient I wanted had did she have a borderline personality disorder, or did she have PTSD? She saw a psychiatrist, and that's what psychiatrists are really good at, giving you a label. And he said she has PTSD, which was good, because at least we could work with that. I've been trying to get her into therapy, but she's been resisting, but that's another issue. Another situation that can be quite useful is a patient having panic disorder? Because if you're 20 years old and you're turning up to an emergency department with crushing central chest pain, and of course you get brushed off, they get sick of seeing you. If somebody just says you're having a panic attack, you need some attention to your anxiety, I think that's useful diagnosis. The other one I had was a Maori man who was 49, brother with schizophrenia, and he was very depressed and a bit paranoid. But when the psychiatrist saw him, he says he's got a major depressive disorder and a severe social anxiety. And ironically, so we stopped his SSRI and I put him on amitriptyline, and he did incredibly well. He quite liked amitriptyline because I think the side effects made him realize we had to drop the dose down, but he's done incredibly well. So that's 2 out of 400 where a diagnosis has been useful. But most of the time, it's distress with reduced motivation or preserved motivation. And I think we do our patients a disservice if we try and give them a label. And certainly in the computer system, it's quite stigmatizing. And, quite frankly, I think every human being probably has 1 or 2 or 3 or a dozen depressive episodes in their life. It's just normal human suffering, basically. I think Marcia alluded to that. It's just the normal ups and downs. And we can get in there and give people perspective and get them moving. Other questions?
We'll just do one more. We've pretty much run to time, Bruce. So the final question of the evening is, that conversation around HIPs has really stirred up a lot of interest. So people are wondering, how can practices that don't have HIPs acquire one?
Really good question. It's at the moment, because it's through a funded system and we have a very limited amount of trainers in the country, we are prioritizing practices that are going through the public system and are funded to have a HIP. And the practice, a HIP is for 10,000 patients. So 1 HIP per 10,000 patients in New Zealand. So we are prioritizing that, but it's going to get to a point where we will hopefully be offering, this kind of training for practices that are not, part of the rollout.
Okay, great. Well, thank you so much, both of you, for joining us tonight. Hopefully you've all out there in the audience have learned some tips and tricks with regards to dealing with that increased caseload of distress and stress that we're all experiencing at the moment. So thank you, all of those of you out there in the audience tonight, for joining us, and good night.